Okay, so I forgot to turn the recording on, so let's do a rehash of what we talked about. I gave you a case of a 50-year-old man complaining of right low back pain, right buttock pain, calf pain. And I asked you to come up with some hypotheses, and then we explored the hypothesis. So the hypothesis that we generated was piriformis syndrome, disc herniation, radiculopathy, segmental dysfunction, and a calf tear, so two separate things. So my question first on piriformis was, what questions could you ask or tests you can do to confirm that it's piriformis syndrome? And in this case, you're probably better off with a highly sensitive question that would rule it out if the answer to that question is negative. So we know that piriformis syndrome is compression of the sciatic or tibial nerve, depending on where it diverges, but compression of a neurological tissue. So what we expect to see is neurological signs and or symptoms. So the obvious question, given that he's coming in complaining of pain, and you're saying it's piriformis syndrome, is, are these neuropathic symptoms? Are they paresthesia? Is there lancinating pain? Is there coursalgia? If the answer to those three things, those types of pain is no, then the symptoms they're presenting with is not from piriformis. They may still have piriformis syndrome, but those symptoms they're presented with is not piriformis in origin. So we can then also look at weakness. So this is basically a peripheral neuropathy. We look for nerve muscles that will be affected and areas of skin will be affected, and we expect to find them. So if there are no neurological signs and no neurological symptoms, there is no justification to claim it's a neurological condition. That is not piriformis. Same thing with radiculopathy. Very definite operational definition. It's neuropathic pain or paresthesia. Really, we should include paresthesia as a painful sensation, but neuropathic symptoms and or one or more of the following. Segmentally distributed weakness, segmentally distributed hypoesthesia, segmentally distributed reflex changes. I think that's it. Okay, so we're expecting to see all of that happening. So we'll come back to disc herniation, and the reason that disc herniation was chosen, somebody told me, was because of the extensive referral of the pain below the knee. Reasonable. You're just coming up with a hypothesis, and there's a reasonable reason for choosing a disc herniation. So you can get pain below the knee from things other than disc herniation, including segmental dysfunction, sacroiliac joint dysfunction, and particularly sacroiliitis. So remembering that the potential for referral is not necessarily about the tissue that's compressed, but where the lesion lies, how central is it, how intense the pain is, how long you've had the pain, and how deep the structure is. So those four things all potentiate referral. Not the actual pathology. Now, the dura is particularly prone to referring because it has an extensive continuation. The thing is continued for a long way, and it has overlapping innovations. So it's a deep structure, so it tends to be able to refer more than most other non-neurological tissues can. Okay, but it's a reasonable reason for arguments of disc herniation. So we started talking about the illness script for a disc herniation, and we struggled a bit until I reminded you, I walked you through it. And we're looking for the illness script and then the essential illness script. And I had to walk you through it a little bit at a time by labeling things. What about the pain? How does the pain seem? How does it behave? And so on. And then we started to come up with answers. So we need intense pain. Disc herniations have severe pain. They have a lot of referral. They produce both flexion and extension impairments, considerable flexion and extension impairments. The range of motion shows all movements affected, significantly affected by it, and all movements painful. There's usually fairly gross deformity. There's usually a rotoscoliosis rather than the straight lateral shift that you see with Mackenzie. So all of this sort of fits in with it. And I said to you, the answers were that, yeah, he can't walk, he can't sit, they bother him. So flexion and extension. We then looked at it being a two-prone problem. That is, the sources. Some of the pain was coming from the lumbar region, some of it was coming from the calf itself. And I said the reason to believe that is that this wasn't a continuous pain from the lumbar spine down to the calf. I said it was right low back, buttock, calf pain. I never said anything about the thigh, and I said it's something you've got to watch for when I'm giving this stuff out. I need you to think about what I'm actually saying. And so you can get distal referral without proximal referral, but it is unusual to the point of rareness. And these gaps in the referral pattern are also unusual. So straight away, that would lead me to think there might be two problems there. Now, having done that, I don't make a hypothesis about what's causing the lumbar spine, nor a hypothesis about the calf. The initial hypothesis is I have two distinct problems. And I have to prove that before I worry about the pathology causing them. So, okay, so you're looking at associating, dissociating, coupling, decoupling symptoms. Do they both come on at the same time? If you had one for years and the other one's brand new, is it a progression of an old condition, or is it a new condition? Can you get the calf pain without the back pain? Can you get the back pain without calf pain? Is the calf pain related to the severity of the back pain? And all of this, if this was referred pain, you would expect to see the calf pain absent when the back pain is present sometimes, but you would never expect to see the calf pain present when the back pain isn't. You would also expect to see the calf pain present mostly when the back pain is more intense. So it was like we talked about headache and dizziness and neck pain. It's a matter of associating, dissociating these two symptoms. At the end of this, you should be able to say they're sourced from the same source, or they are sourced from different sources. So then you can worry about the pathology. Now, if we take that scenario, and what I gave you for the disc, the hypothesis of the disc, I said the pain was severe. I didn't say where it was severe because nobody asked me. So I said the pain was severe. He has flexion extension problems. And there was, given that, there was a lot of referral. So you talked about the range of motion in the back. You should see a flexion extension loss. And your problem is he can't stand up. He cannot stand without being somewhat on his toes. So you're going to have to be very careful about how you do your range of motion. The straight leg raise would be negative for a disc herniation because if I do a straight leg raise for a disc herniation, this is likely to be positive at 30 degrees or even less. It's a very early positive on straight leg raise. Neck flexion may or may not increase the pain. It may actually decrease the pain depending on the site of the disc herniation. Calf dorsiflexion will increase the pain because you're stretching and enduring from that side. If you need to do a straight leg raise and then need to do dorsiflexion of the foot to reproduce the pain or to produce pain in the calf, then probably you're stretching the calf. So you need a very positive straight leg raise to say it's positive for a disc herniation. So you get that not by ruling out the disc herniation, because that's very cumbersome and it's prone to a lot of error and bias, but by saying this may be two problems and then proving the absence of two problems or the presence of two problems and then going from there. Don't do it the other way around. Okay, so what can the lumbar spine can now be a disc herniation? It could still be something like sacroiliitis. It could be something nasty. We don't actually know, but I'm not too worried about that. You can then worry about the pathology there. The calf one was what we concentrated on, and I said, if this is a calf tear, what do you expect to see? And what you gave me was essentially an illness script for an acute calf tear, which is reasonable because you probably haven't seen a degenerate one. Not because they're uncommon or rare, because I don't believe they are. It's because they tend to happen to older people who put up with this shit. rather than a whiny athlete who goes and moans about every ache and pain they get. So the older people put up with it because that's what they expect. They expect pain as they get older. And I told you I had one. I got this, for whatever reason, in my left calf. I take the dog for a walk, and as I said, everything's uphill. There's no downhill parts of my walk at all. I still don't know how I'll get home without going downhill, but I never seem to. Everything is uphill. And I put a small tear in it. It took a couple of days of walking, and then I started to use a cane going up hills, and I'm fine with it. I could probably do without a cane, but why would I? It also helps walk up hills because these are bitches around here, these hills. Anyway, I probably wouldn't have got to see care for it unless it was a chronic thing that was really bugging me, stopping me from doing things I want to do. In actual fact, any reason not to exercise is a good thing for me, so I would never have got to see to. You would never have seen it. Occasionally, these degenerative ones do come to your attention because they completely rupture. It's often the tendon, but it can be the muscle, and you get a complete rupture. So you see this thing balled up. It's often biceps. So this thing is sitting there like that. But if you go online, just put spontaneous rupture of biceps, and you'll see most of these are older people, and it's really obvious what it is. So the question was, how do you do it? Well, you may not see swelling, or if you do see swelling in the calf, it's going to be very, very minor. You're not going to see much in the foot. There's not going to be redness there. It will be tender. And I asked you what test you would do, and isometric testing came up, and I said the chances are that's going to be negative because this isn't a severe tear. What he can't do is put his foot flat on the ground, so stretching will be positive. Okay, fine. Now, if isometrics are positive and stretching is positive, you can be fairly sure of what your problem is. And then palpation should tell you whether it's gastroc or possibly cilius. The other thing you can, of course, do with cilius is flex a knee and then stretch it. You should get more, the same amount of stretch as you got before, whether if it's gastroc and you've got the knee extended, you're going to have less ability to dorsiflex the foot. So you can start thinking about this as cilius. I also said that if the pain is above the divergence of the two heads, then it's almost certainly cilius. It's difficult to it can be gastroc when you're not palpating it anymore. So we talked about differentials, and one of them was shin splints, posterior shin splints. And how do you differentiate this? Well, mostly posterior shin splints occur in athletes, overtraining, the muscle bulks up too much, the connective tissue, the fascia, doesn't go with it, and so it strangles the muscle and it makes it ischemic. This is a 58-year-old man. I'm going to give it to you. He hasn't started being athletic all of a sudden. If he was, it's a different matter. But also the pain from shin splints, you may get point tenderness, but the pain tends to be spread over a bigger area. So plus the fact, shin splints comes on after a while of walking or running. This is immediate. He cannot walk at all. So everything says this is not posterior shin splints. The other thing that gives you calf pain, we talked about, and we came up with it obviously, was this was a DVT, or it could be a DVT, and that's exactly what it could be. And your problem is the tests you do for a DVT are pretty much the same ones as you do for a gastroc, for a calf tear. That is Homan's test, which is simply stretching the calf muscles and palpation. Now, you said that you should see swelling in the foot, redness around if it's a DVT, redness in the calf, swelling in the foot, maybe discoloration of the foot, coldness, and so on. The other group told me that the dorsal pedis artery would also be obscured, and that's not necessarily true at all. Remember, this is a venous problem, not necessarily an arterial one. So the way classical DVTs occur is exactly what you said. That is swelling in the foot, discoloration, and redness in the calf. There's your classic DVT. If that is what you saw, you wouldn't even be considering this as a tear of gastrocnemius. So if this is a DVT, it's an atypical DVT, and this was also an atypical calf muscle tear for you, because you don't see degenerative ones very often. But as soon as you understand that you do get degenerative tears, then it isn't atypical. It's actually a very typical presentation of a degenerative tear in the calf. like one that's not ripped through the tendon and that, but like a small tear, small degenerative tear in the calf muscle. So your problem here is differentiating between an outlier of one and an outlier of the other, and this is where it gets difficult. Outliers don't behave like classical ones or typical ones. They behave atypically, and you've now got two atypical presentations, at least for you. So differentiating isn't easy. This is my question. Which way would you rather be wrong? Would you rather be wrong in sending this to the emergency room and having it come back as negative and it's a calf tear, or would you rather be wrong as treating it as a degenerative tear and it be a DVT? Which way would you prefer to be wrong? And that's your choice, which one you go with. I think you need to be fairly sure that it isn't a DVT before you stop treating it like a DVT, and I don't know that you can do this. I told you a story about when I was working in BC in a clinic there, and I had a really good doctor who used to refer a lot to me, very bright guy, very good clinician, nice doctor. Never ever met him. We did everything over the phone. But he sent me a 65-year-old woman once with calf pain. She got it stepping down off of the curb. And I looked at her and I had no idea why, but I wasn't happy. So I phoned him up and said, I'm not happy with this. He said, no, neither am I. I sent her for a venogram and it's negative. But you're not happy with it? I said, no. He said, send her back, we'll do it again. Did a second venogram, sent it back to me, looked at it again. I went, no, phoned him up again. He said, okay, we'll do another one. Third one came back positive. Neither of us knew why we suspected that. Neither of us. So I can't explain to you. It's a lousy teaching tool, except to say, go with what you've got. Now, the consequences are what matters here. The consequence of you getting this wrong the wrong way could be fairly dire. So it's up to you, but I think that if I wasn't sure, I'd send it to the emergency room. Okay, that was it. We spent the best part of 50 minutes on that, and I don't know how long it's taken us to do it, but probably about 10 minutes. I'll send this out to you, and I will talk to you next Sunday. All right, guys, take care. Bye.